Hello, and welcome to the Dacera Clinical Education Oncology podcast. I'm your host, Ryan Topping. Today's episode features Dr. Jesus Berdeja from the Greco-Hainsworth Centers for Research at Tennessee Oncology in Nashville, Tennessee, and Dr. Ajai Chari from the UCSF Helen Diller Family Comprehensive Cancer Center in San Francisco, California, as they discuss health disparities and equitable care strategies in multiple myeloma, including treatment for underserved populations and keys for everyday practice. This episode is part of a larger educational program titled Advances in Multiple Myeloma, Patient and Expert Insights on Translating the Latest Breakthroughs into Equitable Care. For more information, along with a link to the larger education program, please visit the show notes for this episode. Now, let's get started and hear what our experts have to say on this important topic.
My name is Jesus Berdeja. I'm the Director of Myeloma Research at the Greco-Hainsworth Centers for Research at Tennessee Oncology, and I'm joined by my colleague, Dr. Ajai Chari.
Hi, Jesus. Pleasure to be here with you today. Ajai Chari. I'm the Director of the Myeloma Program at University of California, San Francisco. And today we'll be talking about health disparities. Jesus, I think there's so much advancement in myeloma that we've seen, and it's really gratifying, but unfortunately not everybody's benefiting. What have you noticed, and what are your thoughts on disparities in care in myeloma?
Yeah, I think what's interesting is when we talk about disparities, I think based on the history of clinical trials and healthcare, we immediately start thinking about race and ethnicity, which still remains a huge challenge in terms of access to care. But I think increasingly we're starting to see more and more that there's more to that there are other things like socioeconomic status, healthcare literacy that are really starting to impact the likelihood that a patient is going to get some of these therapies that are working wonders for patients these days. What do you think about that, or what have you noticed?
I think recently we've had some FDA scrutiny, appropriately so, on randomized phase 3 studies where we had a positive result, but the representation of American patients was quite low, and in specifically African-American patients. And so there's really this push to increase the representation of all patients in clinical trials, because clinical trials are meant for cherry-picked patients, of course, that have perfect organ function, that are meant to show the efficacy and safety profile of a drug. And including in that should be the patients that we're seeing in the real world. And so folks that are underrepresented in clinical trials, in addition to African-American, would be frail, elderly, persistent renal failure, cytopenias. We now know that cytopenias also is linked to race in the sense of Duffy null status. Patients with African ancestry will have a lower neutrophil count, which is clinically not significant. And yet, if we have cut points for study eligibility with higher neutrophils, we're excluding unnecessarily patients. And so I think part of this is the study population. But the other part I would say is some of these same groups are really not even getting to academia. And we know that in recent data that patients who have contact with an NCCN-designated comprehensive cancer center, it's an independent prognostic factor for better overall survival. But not everybody can come to an academic center. And so in addition to the groups that you highlighted, in Northern California, we have very rural parts of the state that don't have a lot of cancer care. And we need to use video visits and also get these patients to try to be working partnership. But so I think those are some of the things that I've seen. And I'll say, I think one strategy, as I alluded to, is really harnessing video visits to try to get expand at the connection between academia and community. But any other strategies that you think we should be thinking about?
Before I go to any other strategies, my God, you made so many points that I completely agree with, and I want to expand just a little bit on some of them. But I think you're right. One of the things that's very interesting to me, when I first joined Tennessee Oncology and the idea of sort of taking clinical research to the community, the whole idea was to try and reach those patients that couldn't get to the big academic centers, but also to try and really get these novel therapies to the practitioners and the patients to have some experience in a more controlled setting, so that when the drugs got approved, it was easier to implement them. And part of what you said about the limits of the clinical trial eligibility, I think really backfire on that approach, because what's happening is those patients in the real world that don't meet all those very strict eligibility no longer are then evaluated on the trial, and there are no sort of strategies to help kind of how do we treat a patient with a phenol that we know is going to have more neutropenia with a new cell line, for example, right? Is that just as dangerous as someone who doesn't have the phenol? Because it may not be, right? The numbers are not the same. So neither us as investigators, nor I think sort of the practitioners in the world or the patient really benefit from excluding all those patients. So I think all those strategies that hopefully will start to be implemented to help expand access, I think will help all of us, not just some of those subset of patients that are currently not being addressed. But the other thing actually I want to touch on, and I'm curious what you think about, was you brought up an excellent point that I think for a lot of our new therapies are being approved based on randomized phase 3 trials, as they should be. But as you said, it is very difficult to get US patients onto some of these phase 3 trials because some of the control arms are either felt to be inferior or no longer the standard of care. And you're right, the FDA is pushing significantly on that. I'm curious as to how do we rectify that? How do you see that changing to ensure that we participate in these trials as well?
So I can think of a recent CAR T clinical trial where patients are randomized to CAR T or a very good control arm that was CD38 carfilzomib dex. And in this moment in time, that's a great control arm. One caveat I'll make is sometimes clinical trials are criticized for the control arm, but we have to keep in mind we can't use the retrospectoscope, right? Like when these studies were designed, which is potentially a year to 3 years, the regimens that are getting approved now weren't available then. So if we're always criticizing every phase 3 study, we'll never win and advance the field. And it's just what was the best control arm at the time the study was designed is really the question, is how it should be asked. And ideally, you want to be a little bit of forward thinking, because if you know something's about to imminently approve. But the problem with the regimen that I mentioned is, again, I had several patients that were interested and willing to participate, and willing to be randomized, but are they going to trek all the way down to an academic center that's 3 hours away when they can get that same regimen outside their door? And this is what distinguishes US with its geography from a lot of our other colleagues in Europe, for example, where the countries are much smaller and the patients don't have to go such long distances. So I think one of the things we need to work on as a community is to improve, and you've done a lot of this and you can share your experiences. I would love to hear that. But it's, can you enroll a patient, but they get their standard of care therapy locally, which means that the lab has to be certified, the pharmacy has to be certified, that the physician has to be certified, and there's a lot of vetting that needs to be done. And so I think that is a complicated issue. And several other things that came to mind with the disparities work, we should highlight that probably some data suggests 40 to 50% of real world patients are actually not eligible for studies. So when we have these big data gaps, we need to figure out, one of my other pet peeves is that the way oncology drug design is done is that to get an accelerated approval in an unmet need, you need to get a response rate. And to get that response rate, you push the dose to get that optimal response rate, but then there's no thought given to, is that dose actually deliverable in the real world? And so then we end up having to step back and figure that out. And I think we got to make it patient friendly. And now the FDA is appropriately pushing back on these single arm phase 2 studies and forcing randomized dosing strategies so that we can really pick the best regimen. And I think that's another good way of improving the field. And then I think also another barrier, which is we need to address to getting these approved regimens into the real world, is the REMS program. So a lot of these new therapies like bispecifics and CAR Ts, which are off the shelf and should be in the community, but because they have a REMS program, many docs who maybe treat 1 to 3 myeloma patients a year may not be as excited about doing that. But it's important that everybody does these, because the very patients that benefit from off-the-shelf therapies are these patients that we've been talking about that excluded from the clinical trials, right? So curious to hear your thoughts on that. And also in particular, if you've had any thoughts on the VA system, which I think is a fascinating, but we'll go to the...
I know this is one of your pet peeves, and I think most of us is this whole REMS thing. And I think that the thing about REMS with things like bispecifics, for example, is that the REMS is really based on cytokine release syndrome and ICANS, which just only happens during the step-up dosing and maybe the first dose, and never really happens after that, or the incidence is so infinitesimal that it shouldn't be a requirement for someone who's just going to take the patient over after that step up. And yet it's required for something that they may never see. Now, it's one thing, obviously, if you plan to do the whole treatment, yes, if that's what it takes, that's one thing. But it's always struck me that the REMS system is so inflexible.
And histologically discriminates, right? Because only myeloma products get myeloma bispecifics have REMS. The lymphomas don't.
I was trying to get you to say that, but and I knew it would come up. But I think we're running out of time here. So you mentioned something that I just want to touch on was the whole telehealth and how do we expand access to patients who can't come to us? And I think that's one way. One of the things that, again, there are a lot of difficulties with trying to do this from a standpoint of separate centers in one place and then the local therapy or the local site being completely separate from the center, where I think there are some rational ways to try and do this. Remember, there are very large practices in the US, and I would venture to say that the majority of patients taken care in the community probably belong to these large networks of private practices that should be able to operationalize this whole idea of having, if they're going to have a spoke and wheel model where you have centers that are more sophisticated and then the other centers are where the patients are more further away, there is a way to potentially see the patient, put them on a clinical trial, or start a treatment that may be logistically difficult. But then when they go back to their clinic, there's no reason why that patient can't continue to be followed there, continue to do a telemedicine visit with the primary center to help the local doc and the local patient oversee and anticipate some potential issues and continue to basically handhold as needed those patients. We're starting to do something like that. And I think it's been really welcomed by patients. They really like the idea that they can go to the local clinic, be assessed by the nurses, get laboratories, and then do a telemedicine visit with me 3 hours away and tell them that they're on their bispecific, they're doing fantastic. I think we need to de-escalate the frequency of therapy, and then I can reach out to their doc and have them do that. And I think things like that will eventually become more commonplace and which should definitely help.
One hopeful note to conclude this segment would be that population, we know sometimes African Americans not only are underrepresented in clinical trials, but their outcomes are sometimes inferior to non-African American patients. But the veterans system, which normalizes the access, you don't see that disparity. And it's a good example of how when we give everybody the same care, we see the same outcomes. And it's really important to get these amazing products. So I think to summarize this segment, some of the disparities that we've seen are the race, frail, elderly, poor health literacy, rural patients. And we need to try to expand access, perhaps by telehealth, taking advantage of hub and spoke models, and increasing representation of these patients by increasing the eligibility permissiveness of these phase 3 clinical trials. And then we can get everybody these amazing products.
Yeah, couldn't agree more. Thank you. That was excellent.
Thank you, Dr. Berdeja and Dr. Chari, and many thanks to you, our listeners, for joining us. As a reminder, to view the full program, Advances in Multiple Myeloma, Patient and Expert Insights on Translating the Latest Breakthroughs into Equitable Care, please click the link in the show notes. And be sure to check back regularly for more episodes on important DeSera Clinical Education Oncology podcast topics.